Arun, ready?
Start பண்ணலாம்.
Shall we start? Shall we start? Students, are you there? Shall we start? Just an hour of class, a basic introduction on IEM along with some finer points regarding an approach to hypoglycemia. Shall we? Yes. A great new year to you all. All the best wishes for your future examination. Study with the love. Everything else will happen automatically. Okay? Right. So the need of the hour is not concentration. The need of the hour is not hard work. The need of the hour is put everything with your heart and soul. That is called passion. Study with passion. Definitely, whatever it may be, you can achieve your goal. Right. The first topic today, we are going to discuss about a small session, a small introductory session on inborn errors of metabolism. So as far as any inborn errors of metabolism, you must be remembering that we need carbohydrate, we need fat, we need proteins, everything to supply energy demand for our daily day-to-day routine activities. So what will happen if something happens to hinder the pathways, whatever it may be, whether it is a carbohydrate metabolism or protein metabolism or fat metabolism or any other thing? What will happen if there is a deficiency of an enzyme which is responsible to provide you energy? That is what we are going to see right now. So instead of complicating things, let us deal with an easy example. Let me tell you, for example, you have an enzyme called phenylalanine. So let me write, you have an enzyme called phenylalanine. Just listen, no need to write. You have an enzyme called phenylalanine. This phenylalanine is metabolized to tyrosine. This tyrosine in turn metabolized to melanin. So what are all the enzymes involved in this? The main enzyme that is involved in this pathway is phenylalanine hydroxylase. So let me write, hydroxylase is the enzyme that is responsible for catabolizing or converting your phenylalanine to tyrosine. What will happen if a child is born without any phenylalanine hydroxylase? So for example, a child is born of consanguineous marriage. If the newborn baby lacks this phenylalanine hydroxylase, what will happen? So let us presume that the newborn baby is not having phenylalanine hydroxylase. So the breast milk contains all essential carbohydrates, proteins, fats. One of the essential amino acid in the breast milk is phenylalanine. This phenylalanine for catabolism, for metabolism requires hydroxylase to get convert itself into tyrosine. For example, if there is no phenylalanine hydroxylase, what will happen? This phenylalanine, what do you mean by that? It is a substrate. This phenylalanine will not be converted to tyrosine, as a result of which the phenylalanine will be increased in the blood and your tyrosine will be decreased in the blood. Because of the reduction in tyrosine, your melanin also will be decreased. So what are all the unforeseen circumstances that can happen as a result of this absence of phenylalanine hydroxylase? Let us see. Because of an unprecedented increase in the phenylalanine, this phenylalanine in turn can cause the can cause an injury to the developing brain. So majority of this phenylalanine becomes toxic to the developing brain. As a result of which a newborn can develop seizures. Second point, because of the chronic damage that can occur to the brain because of the high phenylalanine levels, the child can go for microcephaly. And because of the chronic damage to the developing brain, the child can go for mental retardation or developmental delay. Instead of using the term mental retardation, let me use the term developmental delay. So you will have developmental delay. Okay? So one is due to the increase in the substrate in the form of phenylalanine. This phenylalanine in turn causing damage to the developing brain, leading to seizures, leading to microcephaly, leading to developmental delay. When you go to the other side, what will happen to the product? The product tyrosine is not formed inadequate. As a result of which, melanin will also not formed, leading to reduced melanin. You all know that melanin is responsible for causing pigmentation of the skin. Absence of melanin leads to absence of pigmentation, leads to what? You can say albinism. And also, melanin protects you against so much of allergic disorders, particularly eczema. Because of the absence of melanin, you can get chronic eczema too. So what are all the manifestations of a phenylketonuria? The manifestations of phenylketonuria are: one, because of increase in substrate, that is your phenylalanine, you will have microcephaly, developmental delay, and seizures. Two, because of the reduction in tyrosine, you will have reduced melanin, leading to albinism and chronic eczema. So these are all the manifestations of a phenylketonuria, right? Because of the absence of phenylalanine hydroxylase. What is this called? This hypothesis, that is, the manifestations of phenylketonuria is due to one, increase in phenylalanine, as well as it is due to decrease in melanin, that is substrate. So this happens good for any kind of inborn errors of metabolism, and the hypothesis that describes these manifestations is known as Garrod Hypothesis. So who had described these manifestations? Mr. Garrod has described, and this is called Garrod Hypothesis for inborn error of metabolism. Hypothesis for inborn errors of metabolism. That is, increase in substrate and decrease in product both can have a manifestation in the developing newborn. Right. Sir, what are all the treatment options that are available to treat any case of inborn errors of metabolism? Before that, what will be the manifestation? So concept number one is what is called Garrod's hypothesis. One. Second, let us go for concept two. So what is concept two? Remember, you all know that almost all inborn errors of metabolism are due to defect or absence in the enzyme. You all know that enzyme related disorders are autosomal recessive in nature, because the enzyme should be absent from both chromosomes, that is, from both parent and from both mother. Only when then the disease will manifest on its own. That's why it is autosomal recessive in nature. Almost all inborn errors of metabolism are autosomal recessive in nature. We have some exclusions. We will come to those points later. One. invariably you will have an example of, or you will have a history of consanguineous marriage. Invariably, you will have an history of consanguineous marriage. Second, third, invariably there will be history of death during the neonatal period or infantile period. So death because of untreated inborn errors of metabolism. There will be family history of sibling death. There will be family history of sibling death. Will be there. Third. Fourth, when these inborn errors of metabolism can manifest with, it can either manifest as an acute inborn errors of metabolism, or it can manifest as chronic inborn errors of metabolism. Sir, how do we say whether it is an acute inborn errors of metabolism or chronic inborn errors of metabolism? Remember, acute inborn errors of metabolism are mainly due to reduction in the substrate that is required for our day-to-day activity. For example, you need glucose for your day-to-day activity. When you don't have glucose, for example, you might have a problem in the enzymes involving glycolysis. You might have a problem in the enzyme involving glycogenolysis, or you might have a problem in the enzyme involving gluconeogenesis. In all these cases, the main manifestation will be recurrent or persistent hypoglycemia. Recurrent or persistent hypoglycemia, which can lead to convulsion. This is one example. For example, it can also be due to, for example, when there is an absence of B12, which is responsible for converting your methylmalonyl-CoA to propionyl-CoA. What will happen? Methylmalonyl-CoA, methylmalonic acid will increase in the blood, leading to tremendous increase in acidosis, leading to lethargy, refusal of feeds in a developing newborn. Lethargy and refusal of feeds will be developing in the newborn. So, what are all the manifestations of an acute IEM? So, let me think in this way. You are working as an intern, right? You are working in the newborn ward or labor ward. A child is born full term. A child is born full term. Example, think that you are working in the labor ward or a newborn ward. You are seeing a child, you are asking the history, you are seeing the child on the first day of life, right? So you are asking the history. Now, what about you are asking the mother? Is it a term or preterm? It is a full term. Point number 2, right? Is there any even full antenatal history? Mother told that antenatal scans are normal, sir. Okay. Whether the child cried immediately after birth? The answer is yes. Yes, sir. The child cried immediately after birth. Amma, what is the weight of the child? The weight of the child, let me say 3.5 kgs. Okay, fine. And you are examining the baby from top to bottom. So from top to bottom, you are examining the child from head to foot. The child is absolutely fine. So external examination, normal. You just listen, no need to write all these things. External examination is normal. So you are happy. Then you are advising, ma, you need to give exclusive breastfeeding. No need to give anything apart from your breastfeeding, and you are encourage the mother to go for breastfeeding, and you are teaching the mother about the good breastfeeding technique. And you have taught the mother is happy, the grandmother is happy, the entire family is happy because of the friendly approach of you towards the family and towards the kid. Point number 1. Then you come to your room. You are taking a good nap because of the 36 hours of work, continuous work. On the 3rd day of life, okay, you are about to go to the ward to see the child again. But before that, you are getting a call from the staff nurse. The staff nurse is saying, sir, the child is lethargic, not able to take feeds, and the child is throwing convulsion. Suddenly you are rushing into the newborn ward, postnatal ward, and you are looking at the child. The child is having lethargy, refusal of feeds. Okay, the child is not taking feeds. The child is having a refusal of feeds. So what you are, yes, fantastic. One such differential diagnosis is galactosemia. You are well appreciated, my dear. Right, the child is lethargic. The child is having a refusal of feeds, and you are checking the blood sugar. The blood sugar was just 20 milligram per deciliter, and you are infusing the child with 5 ml per kg of 10% dextrose. And the child is revived, and you are maintaining a glucose infusion rate of 6 milligram per kilogram per minute, which is the normal required day-to-day requirement of glucose. Right? The mother is asking, sir, yes, ma, tell me. You told me that my child was absolutely normal on the first day. Yes. After examining, you told everything is fine. Yes, but yesterday also my child was doing fine. Yes, you told me to give exclusive breastfeeding. The answer is yes. But since today morning, despite giving breastfeeding, the child is slowly developing lethargy, sir, not taking feeds, sir, and suddenly the child is showing convulsions, sir. Could you tell me what had happened to my child? You are asking. So now you are seeing a case of hypoglycemia. You are asking whether there is any risk factor for hypoglycemia. You are asking the mother, are you feeding the baby frequently? Yes, I am feeding my baby frequently. Absolutely fine. Do you get enough breast milk? The mother said, yes, sir, I am getting enough breast milk. Whenever I feed here, it is drooling here also. You taught me good technique, and I want to feed my mother. I am confident enough to feed. Yes, the breastfeeding is adequate. Is it a child with a preterm, that is born less than 7 weeks of gestational age with the inadequate reserve? No, it is a term baby. It had completed 38 weeks. Okay, I am happy. Now you are asking the mother, is it an SGA baby, that is small for gestational age, and IUGR? In fact, no, it is more than 2.5 kgs. So there is no history of a small for gestational age. Is there any history of birth asphyxia? No. Is there any history of infant of diabetic mother with increased requirement? The answer is no. So the answer is no for any of your question. But despite being normal, why the child had developed this hypoglycemia? That is where the inborn errors of metabolism story is unrevealing. Okay? That is where your inborn errors of metabolism story is unrevealing. So you need to decode the secret behind this hypoglycemia. So, and I also told you, it can also be due to anything. It can also be due to absence of any enzyme. It can lead to severe metabolic acidosis. These acidosis are, in fact, you take a case of phenylketonuria, high phenylalanine levels can manifest in the form of convulsions. So what are all the manifestations that can happen in a newborn with respect to acute IEM? One, because of increase in the substrate, because of the injury produced by the unprecedented increase in the substrate, you can have lethargy. You can have refusal of feeds. Along with that, you can have intractable hypoglycemia. You can have intractable convulsions, not able to stop. with anticonvulsant, you can have intractable vomiting. This is called IAM pented. This is called inborn errors of metabolism. Pented of symptoms: lethargy, refusal of feeds, intractable hypoglycemia, intractable convulsions, and intractable vomiting. Right. So whenever you see this kid, do not think about inborn errors of metabolism directly. You all know that the most common cause for any child after having a normal period of birth suddenly become ill means invariably your dustbin diagnosis is septicemia. Say yes or no? Yes. Invariably, whenever any child worsens on the third day, we will blame the environment and we will blame the microorganism, and we will blame ourselves and our staff nurse for not hand washing properly in between examining the kids. Isn't it so? The answer is yes. But you need to have a microbiological evidence, either a direct evidence or indirect evidence. Sir, do I need to consider septicemia as my first diagnosis? The answer is yes. Even though inborn errors of metabolism are increasingly being recognized, nowadays, each and every institute, each and every PGs are taught to suspect an inborn errors of metabolism during their traineeship. But above all, whatever it may be, septicemia should be ruled out first. So what are all the investigations you are taking? You are taking a total count. You are taking a differential count. You are taking a ESR. You are taking a CRP. You are looking for the immature neutrophils, otherwise known as banned neutrophils. Sir, my TC is normal, DC is normal, ESR is normal, CRP is normal. Immature neutrophils are normal for that age and sex. Okay. Apart from that, this is the indirect evidence. What is the direct evidence? Blood culture, negative. Urine culture, negative. X-ray chest, no pneumonia. Last but not least, LP, CSF, negative. So in the absence of microbiological evidence, sudden worsening on the third day or fourth day of life, in a term baby with a previous history, with a background history of consanguineous marriage, you need to think in terms of your inborn errors of metabolism. You catch my point? Is it clear for you, my dear kids? Is it clear for you? What I am dealing with, is it clear for you? Okay, done. Thank you. So, yes, the answer is yes. So, this is how you need to suspect your inborn errors of metabolism. Right. So, let me. So, sir, what is the manifestation of chronic inborn errors of metabolism? Acute inborn, sir, again you can ask me one question. Can it happen only during the newborn period? It doesn't look like that. Can it happen somewhere else? The answer is yes. Because when you have an absolute deficiency of an enzyme, it will manifest in the immediate newborn period, but definitely not in the first 2 to 3 days of life. The answer is because in the first 2 days of life, the increase in the substrate, okay, has to reach a specific threshold level to produce that corresponding damage to your body. That's why invariably in the first 2 days of life, the substrate gradually accumulates to produce the damage on the third or fourth day of life. One. But when you have a just sufficient number of enzymes, when it can happen? It can happen on the third month or fourth month of life whenever you get caught here. Viral cold and cough. Majority of the time, these inborn errors of metabolism will manifest on the third or fourth month of life when the child gets cough and cold, because When you get a viral cough and cold, your catabolism increases, your requirement increases, the demand increases because of the catabolism. But your insufficient enzyme are unable to keep up the demand produced by the catabolism occurring as a result of a viral infection. So it will manifest. So it doesn't mean that it has to be manifest in the immediate newborn period. It can manifest in the early infantile or late infantile period when the child catches some other illness, usually a viral respiratory coryza. Okay. So what is the manifestation I told you? A well-appearing child born of consanguineous marriage without any evidence of sepsis, suddenly developing lethargy, refusal of feeds, intractable vomiting, intractable convulsions, and intractable hypoglycemia. Think in terms of an inborn errors of metabolism. So what will be the manifestation of a chronic inborn errors of metabolism? Chronic inborn errors of metabolism usually manifest as a developed neuro regression. What do you mean by neuro regression? So 2-year-old, 3-year-old child, my child, 2-year-old child, my child able to walk, able to run, able to hear, able to see, everything, able to comprehend what I say. But for the past 3 months, after his second birthday, for the past 3 months, he could not walk, sir. Okay, he is not listening to me, sir. Okay, some problem with respect to hearing, and he could not see. There is some nystagmus I could witness. Okay, and he started losing his milestones. He started losing his milestones. So now he could not walk. Now he could not track. He's staying in one area in particular. I don't know what is happening. This is called neuro regression. And acquired milestones. The child is losing the already acquired milestone. Then we will call it as neuro regression. You lose all the skills that you have learned earlier. Okay, this is called neuro regression or cognitive decline. So a well-appearing child started slowing, losing all the milestones along with visual issues, along with hearing issues. Then you need to suspect about this chronic inborn errors of metabolism. Acute inborn errors of metabolism are due to deficiency of smaller molecule that is essential to carry over your day-to-day life. Whereas chronic inborn errors of metabolism are mainly due to the accumulation of large molecules, either in the gray matter, leading to gray matter degeneration, or in the white matter, leading to white matter degeneration. Bus, full stop. Now you know, my kids are able to diagnose when they need to suspect an inborn errors of metabolism. A term baby born by labor naturale without any evidence of birth asphyxia or any risk factor for sepsis. If the child develops persistent lethargy, refusal of feeds, intractable vomiting, intractable convulsion, intractable hypoglycemia, after ruling out sepsis, my first diagnosis and my first suspicion will be inborn errors of metabolism, sir. You can say point number 1. Point number 2, when will you suspect a chronic inborn errors of metabolism? A child who had attained a milestone now started losing all the acquired milestones along with the visual issues or hearing issues. I will think in terms of a neurodegenerative disorder, otherwise known as chronic inborn errors of metabolism. As I explained you earlier, acute inborn errors of metabolism are due to deficiency of smaller molecules, whereas chronic inborn errors of metabolism are due to accumulation in the large molecules, either in the gray matter or in the white matter. Okay. Now, one such cause for worsening due in the acute inborn errors of metabolism is hypoglycemia. Is hypoglycemia. Okay. So what is that triad called as with respect to hypoglycemia? The triad is called as Whipple's triad. The triad is called as Whipple's triad. So what is that Whipple's triad called as? Even though there are so many confusions or consensus regarding when to say a hypoglycemia, for your post MBBS level, better you need to think in terms of a serum sugar value of more than sugar value of less than 55 milligram per deciliter, along with symptoms of hypoglycemia. So what are all the symptoms of hypoglycemia? The symptoms of hypoglycemia, as we discussed, it can be lethargy, it can be refusal of feeds, it can be perspiration, increase in the sweating, it can be due to increase in tachycardia, hypotension, or a child, if not treated properly, can go for seizures, particularly early morning seizures, and prompt resolution of symptoms with sugar instillation. So, prompt resolution of symptoms. Prompt resolution of symptoms. Prompt resolution of symptoms with 10% dextrose. Bolus. So this is called Whipple's triad. So you need to know the value of less than 55 milligram per deciliter. You need to have symptoms of hypoglycemia and prompt resolution of symptoms with the 10% dextrose. Okay, done. Now, sir, whenever I see a case of hypoglycemia, do I need to think in terms of inborn errors of metabolism always? No, the answer is no. It was explained in our discussion that it is intractable hypoglycemia, not just a single episode of hypoglycemia. That is intractable or persistent hypoglycemia. Intractable or persistent hypoglycemia. Sir, when should I say an intractable or persistent hypoglycemia? Sir, very simple. 1. When the glucose infusion rate, I told you before, the normal glucose infusion rate requirement is 6 milligram per kilogram per minute. If the glucose infusion rate goes beyond 12 milligram per kilogram per minute, you need to suspect an inborn errors of metabolism that is producing a hypoglycemia. So what is the normal level? 6 milligram per kilogram per minute. 1 GM. So second point, so that is increased requirement. Okay, requirement that is beyond the requirement by the normal individuals. A normal individual will require a 6 milligram per kilogram per minute. But a child with some issues with the glycolysis, glycogenolysis or glucogenesis may require more than 12 milligram per kilogram per minute. Second point. Third, persistent of hypoglycemia. Persistent of hypoglycemia beyond 72 hours. Persistent of hypoglycemia beyond 72 hours of life. In these instances, you need to worry about a cause for an inborn errors of metabolism. Persistent hypoglycemia. Second point. Right, sir. Whenever my body goes for reduced substrate, whenever my body goes for reduced substrate, how does my body able to produce glucose? First, in the first 2 to 4 hours of life, you will rely on glycolysis. In the first 2 to 4 hours of life, you will depend on the glycolysis pathway. From about 4 to 12 hours, it is usually the glycogen that is stored in the liver and the muscle will be broken down to glucose. That is glycogenolysis. Third, after 12 hours of fasting, if you develop hypoglycemia within 2 to 4 hours of fasting, the problem is in glycolysis. If you develop hypoglycemia after 4 hours, but before 12 hours of fasting, you have problem in glycogenolysis. If you develop hypoglycemia after 12 hours of fasting, you have a problem in gluconeogenesis. You have a problem in gluconeogenesis. Okay. Sir, can you give me some examples for this? A classical example for issues with respect to glycolysis is hyperinsulinism. Hyperinsulinism, point number 1. Second point, a classical example for glycogenolytic disorder is glycogen storage disorder. You might have heard about von Gerke disease, Cory's disease, Anderson's disease, etc. Third point, gluconeogenesis. What happens in gluconeogenesis? Fatty acids will be converted to ketone bodies and glucose. Proteins will be converted into glucose and ketone body, glucose. So what does it mean by that? Non-carbohydrate substances like fatty acids and the proteins will be converted into glucose. That is called gluconeogenesis. The classical example is fatty acid oxidation disorder. Okay, or there are so many differential diagnoses you can have. So this is the prototype example. This is the prototype example. Third point, prototype example. So we are going to discuss mainly about some examples for these hypoglycemias. Some examples for these hypoglycemias. Right. First of all, we have heard about glycogenolytic disorders. What do you mean by glycogenolytic disorders? Otherwise known as glycogen storage disorder. Otherwise known as glycogen storage disorder. Right. Sir, what do you mean by glycogen storage disorder? Glycogen that is stored in the liver after 4 hours of fasting has to be broken down to glucose to provide the energy required by the body. So what happens in case of a glycogen storage disorder? We have mainly 3 prototypes. What are all the prototypes? Type 1, so type 2, and then usually we have so many prototypes. Let me talk about the glycogen storage disorders involving the liver. So type 1, type 3, type 4. Sir, what is type 1? Type 1 is called as von Gerke disease. What is that called as? Type 1 is called as von Gerke's disease. Type 3 is called as Cory's disease. Type 4 is called as Anderson disease. Is called as Anderson's disease. Sir, what is the example? What is the enzyme that is involved in it? In type 1 von Gerke disease, the enzyme involved is glucose 6-phosphatase. In case of Cory's disease, the enzyme that is deficient is, can anyone tell me? C should be followed by D, a small clue, D branching enzyme. Anderson disease, what is the enzyme that is deficient? A followed by B, branching enzyme deficiency. Branching enzyme deficiency. Okay, sir, you have taught us main 3 types of glycogen storage disorder. What will be the manifestation? How do I know the child is suffering from glycogenolytic disorder? Simple. A child will develop hypoglycemia after 4 hours of fasting. First clue. After 4 hours of fasting. Clue 1. Clue 2. Increase in substrate and decrease in product. Decrease in product. So what does it mean? Decrease in product. The product is glucose. Decrease in product leads to persistent hypoglycemia. That is blood sugar less than 55 milligram per deciliter, lasting for more than 72 hours. or a GIR requirement of more than 12 milligram per kilogram per minute. Second, third point, increase in substrate. So this increase in substrate, where it is occurring in the liver. So you will get a hepatomegaly. So whenever you see a case of, sir, what will be the manifestation of hypoglycemia? The manifestation of hypoglycemia is the child usually brought with lethargy, refusal of feeds, but invariably the most common manifestation is hypoglycemia induced seizures on the early morning, because in the first 3 months of life, you used to feed the baby each and every hour, so there will not be any issue, unless otherwise you have an issue with respect to glycolysis. But after 3 months to 4 months, the child will be able to take feeds only when there is a demand, or only when it is not playful, or only when it is really hungry. So a 4-month-old child, a 5-month-old child, you are sleeping in the wee hours of the morning, particularly in the early morning, and the staff nurse is calling you doctor. A 7-month-old child is brought with convulsion. You are rushing into the emergency room. The child is convulsing. You are securing the venophalon. Suddenly, you are asking the patient, staff nurse, to look for glucose level with respect to with the glucometer. The staff nurse says that the glucose value is just 20 milligram per deciliter. Staff, kindly start 2 ml per kg of 10% dextrose and start a maintenance to simultaneously you send other investigations too. And you are palpating a small liver of 8 to 9 centimeter is seen, spleen is not seen. Now you have a hypoglycemia, you have given an infusion of blood glucose, the child responding to your infusion in the form of regression or resolution of seizures. Now the child becomes normal. You have an hepatomegaly. This is the exact scenario you can see with respect to any case of glycogenolysis or any case of glycogenolysis involving the liver. So what are all the 3 types we had discussed? Type 1, type 3, type 4. Sir, is there any difference to differentiate between these 2? You told that each and everything can manifest with early morning hypoglycemic seizures. On examination, you will have an hepatomegaly, that the seizure responding to anticonvulsant. Responding to dextrose. You told 3 examples, sir. Is there any possibility to differentiate clinically? The answer is yes. The answer is yes. It doesn't mean that you need to go for each and every detailed analysis. Almost all the diagnosis can be brought out with the help of the history and with the help of the simple lab investigation. High funda investigations are required only to confirm the diagnosis, not to suspect the diagnosis. So what are all the 3 glycogenolytic disorders we had discussed, my dear kids? The 3 glycogenolytic disorders that we had discussed are 1, type 1, type 3, type 4. You can write. Type 1 is what? Von Gierke disease. Type 3, Cories. Type 4, Anderson. Basic level question. Next level question. Okay. What is the enzyme that is deficient? Von Gierke disease, glucose 6-phosphatase. Cories disease, debranching enzyme. Anderson disease, branching enzyme deficiency. Sir, you told hypoglycemia, you told substrate accumulation. What is that substrate accumulation, sir? Simple. The substrate accumulation is glucose 6-phosphate in case of von Gierke, whereas it is alpha limit dextran. You must have heard in your biochemistry class, alpha limit dextran. Whereas the substrate that gets accumulated in the Anderson disease is amylopectin. Amylopectin. Right. Okay. Amylopectin. Sir, what else you want to say? Yes, there are plenty of things to say. Remember, almost all, whenever you have an hepatomegaly, whenever you have an hepatomegaly, invariably you will look for what? OTPT. Invariably you will look for what? OTPT, because is there any underlying derangement of liver produced by the underlying substrate accumulation? You want to know. So you are like taking OTPT. So let me write SGOT, SGPT, ALT, AST. Usually glucose 6-phosphate will not cause much injury to the liver. So a mild elevation of SGOT and SGPT or ALT and AST. For example, it is less than 40 means you can have a mild rearrangement 80 to 100, 80 to 100, because it doesn't cause much injury to the liver. But as far as alpha limit dextran is concerned, it causes, it is not such a it is not as harmless as your glucose 6-phosphate. It is little bit harmful to the liver, as a result of which you will get moderate elevation of OTP. Moderate elevated. So let me say 220, just for an example maybe. But amylopectin, the one which causes lethal damage to the liver, leading to cirrhosis. The presentation itself will be cirrhosis, that can in turn leads to pulmonary hypertension and associated spleen. Done. Sir, whenever I do a histopathology, what will happen? I told you G6P is absolutely harmless. So no fibrosis. Okay. Your alpha limit dextran cause a little bit of fibrosis. So fibrosis present. And finally, as I told you, amylopectin will cause much injury to the liver, leading to frank cirrhosis. Okay. Almost in all, the main product is related to glucose and glycogen. So it will be positive for almost all. When you want to stain the histopathology specimen, almost all will be PAS positive staining. And whenever you subject the sample for diastase, which in turn lies the glycogen. So they are diastase sensitive. All are diastase sensitive. So let me complete the picture. So type 1, type 3, type 4, all can manifest with hypoglycemia and hepatomegaly. All can manifest within HP section whenever you do a liver biopsy, PAS positive and diastase sensitive. And all are going to produce an hypoglycemia and hepatomegaly. When you take a LFT, no mild derangement of OTPT in case of type 1, moderate derangement of OTPT in case of type 3, whereas frank cirrhosis in case of type 4. Okay, cirrhosis in case of type 4. Now, sir, is there any other way apart from this to differentiate this glucose, this type 1 and 3? Apart from that, you can take uric acid, you can take lactic acid, you can take triglycerides. So now you have 1, now you have 3, now you have 4. Now you have, let me explain you, doctor, let me explain you again. So type 1 is Van Gierke disease, type 3 is Fori disease, type 4 is Anderson disease. Remember, the substrate that is involved in Van Gierke disease is glucose 6-phosphate. The substrate that is involved in Fori's disease is alpha limit dextran. The substrate that is involved in Anderson disease is what? Amylopectin. Remember, this glucose 6-phosphate, you all know almost all pathways are interlinked with this glucose 6-phosphate. So this unused glucose 6-phosphate will be converted to No, I am here. Don't worry, I am here. Okay. So will be converted to this unused glucose 6-phosphate will be converted to uric acid, will be converted to lactic acid, will be converted to triglycerides. So you have hyperuricemia, lactic acidosis, hypertriglyceridemia in a case of urea cycle disorder. In a case of, type 1, that is Von Guericke disease. Whereas alpha limit dextran will be converted only to triglycerides. It will not be converted to uric acid. It will not be converted to lactic acid. So your uric acid will be normal, lactic acid will be normal, whereas triglycerides will be very high. But your amylopectin neither converted to uric acid, nor converted to lactic acid, nor converted to triglycerides. So everything will be normal, but there will be a frank cirrhosis. Now let us complete everything in one line. Let us complete everything in one line, and you are going to answer right now. You are going to answer right now. Okay, you are going to answer right now. So let me approach like this. Whenever I see a case of hypoglycemia or hepatomegaly, look here, I am seeing a case of hypoglycemia plus hepatomegaly. Hepatomegaly is any glycogen storage disorder, is diastase resistant. One, almost all are sensitive. Diastase resistant is usually your, what is that, alpha antitrypsin deficiency. Okay, so hypoglycemia and hepatomegaly. So whenever you have an hypoglycemia and hepatomegaly, what you need to look for, as I explained you need to look for uric acid, you need to look for lactic acid, you need to look for triglycerides. So now I told you, when uric acid is increased, lactic acid is increased, triglycerides are increased. So what is the type? Tell me, you need to tell yourself. What is the type? It was just discussed. What is the type? When all are increased, type 1. Very good. Type 1. When triglycerides alone increased, but uric acid has not increased, lactic acid is not increased. What is this type? Uric acid is increased, lactic acid is type 3. Very good. Now, when nothing is increased, but hypoglycemia, hepatomegaly, what is that? Type 4. Very good. So now I am going to ask you another thing. Now, let us, another thing is what? So what happened to my SGPT, SGOT, SGPT levels? And fibrosis present or absent. Fibrosis present or absent. OT minimally deranged, there is no fibrosis. So what is the type? So what is the type 1? So OTPT moderately raised, minimal fibrosis. What is that? Type 3. Okay. Now OTPT severely deranged, fibrosis is severe leading to cirrhosis. What is that? Type 4. Now tell me, is it easy or tough, my dear boys and girls? Is it easy or tough? Is it easy or tough? Easy, that's all. Easy, that's it now. Okay. Okay, easy. Sir, now I have a case of, sir, how to prove, sir? This is biochemical evidence, how to prove. So you need to go for enzyme analysis. You need to go for enzyme analysis. So respective enzyme analysis or genetic studies. Which gene is responsible to cause that specific defect in the enzyme? So genetic analysis. So one is direct evidence, another is indirect evidence. So far you know what is the indirect evidence. Now to confirm you need to have a direct evidence. Sir, what is the treatment right now for all these three? So what is the treatment right now? Remember, what is the problem, my dear boys and girls? The problem is recurrent hypoglycemia. The recurrent hypoglycemia occurs only when you go for fasting. So don't go for fasting. Just eat. So 2-hourly feeding. 2-hourly feeding. Okay. Still, we don't have enzyme replacement therapy, my dear, with respect to these GSTs. At present, 2-hourly feeding. I agree with you. 2-hourly feeding. Second point, uncooked cornstarch at night and day. Uncooked cornstarch. So this uncooked cornstarch slowly releases glucose in a periodic basis. So uncooked cornstarch slowly releases glucose in a periodical basis. Avoid. What avoid? You need to avoid what? You need to avoid what? Whenever you have an issue with respect to this, you need to avoid certain things. You need to take frank glucose, cannot be converted into glucose 6-phosphate. Okay. So you need to avoid fructose. You need to avoid galactose. You need to avoid taking frank glucose in case of type 1, because your fructose and galactose are also being converted to glucose 6-phosphate. So you in type 1, you need to avoid, fructose, galactose, glucose. Whereas in case of type 3 and type 4, only you need to avoid glucose. You can take fructose, you can take galactose, because the pathway doesn't involve glucose 6-phosphatase. Apart from that, what can be done? It is right now we don't have enzyme replacement therapy. In type 1 and 2, frequent feeding, cornstarch, uncooked cornstarch food. Whereas in type 4, whenever you see the kid, the child will be having cirrhosis and portal hypertension. So you need to go for liver transplantation. You need to go for liver transplantation. So this is the treatment for GST type 1, 3 and 4. This is the treatment for GST type 1, 3 and 4. Is there any difficulty in understanding these basic concepts? Is there any difficulty in understanding these basic concepts? Okay, done. Sir, what else we need to know, sir, apart from this? So let me finish. This is Thaimasam Pongal. We are just starting the day. So let me finish within 15 minutes. Okay, max 15 minutes. Right. Now, there is two other glycogen storage disorder with respect to liver. What are all they? Type 6. Okay. And then type 9. Type 6 and then type 9. That is due to, type 6 is due to liver phosphorylase. And type 9 is due to phosphorylase kinase. Phosphorylase kinase. Sir, what happens to this 6 and 9? 6 and 9. Let me tell you what happens to this 6 and 9. They can have intermittent. They are not that severe. They can have intermittent hypoglycemia, minimal hepatomegaly that improves in and around puberty. So type 3 and 6 and 9, liver phosphorylase and phosphorylase kinase deficiency can manifest with intermittent hypoglycemia and minimal hepatomegaly, which resolves around puberty. And someone had mentioned, what is type 0? Type 0 is due to hepatic glycogen synthetase deficiency. Hepatic glycogen synthetase deficiency. Hepatic synthetase glycogen deficiency. So this is all about your liver glycogenolytic disorder. This is all about your liver glycogenolytic disorder. Sir, what about muscle glycogenolytic disorder? Remember, whenever you have issues with respect to the liver glycogenolysis, the manifestation will be hypoglycemia and hepatomegaly, because they are required during periods of fast. But when you have issues with respect to the muscle glycogen, what will happen? Yes, as you told, they are type, what are all the type? Type 5, type 7. Type 5 is called as McArdle's disease. Type 7 is called as Torres disease. McArdle's is called as is due to deficiency of myophosphorylase or muscle phosphorylase. Whereas Torres disease is due to phosphofructokinase. Sir, as I told you, always, you need to be a good clinician. How come a case of McArdle's disease and Torres disease will manifest? Sir, whenever I play vigorously, I develop muscle cramps. I develop muscle cramps on exercise. At times, it leads to myoglobinuria and red-colored urine. At times, it can lead to acute renal failure, tubular necrosis. So, the main manifestation of McArdle's disease and Torres disease is exercise-induced muscle cramps. I repeat, whenever any child comes with exercise-induced muscle cramps on daily, day-to-day basis, consider in terms of McArdle's disease or Torres disease. Okay. Invariably, when it is not attended properly, it can lead to red-colored urine or myoglobinuria. Sometimes it can lead to acute renal tubular necrosis. So we had completed hepatic glycogen storage disorder. We had completed muscle glycogen storage disorder, and finally, muscle, we are left out with one. What is that? That is type 2. So type 2 is called as Pompe's disease. Just 5 minutes. We are winding up. Pompe's disease. Here, the glycogen is accumulated in the heart. The glycogen is accumulated in the heart. The glycogen is accumulated in the anterior horn cells. So what will happen? Anterior horn cells. Let me revise once again. Okay, anterior horn cells. So whenever you have this accumulation, sir, what is the enzyme? The enzyme that is deficient is. The enzyme that is deficient is. Okay. Yes, the enzyme that is deficient is. What is the enzyme that is deficient? Can anyone tell me? What is the enzyme that is deficient? Acid maltase. Acid maltase. So whenever this enzyme is deficient, the substrate will accumulate in the heart, leading to massive cardiomegaly. One. And also, because of the increase in substrate in the anterior horn cells, they will be destroyed, leading to floppy infant. So massive cardiomegaly, floppy infant. Along with that, they have large tongue. So whenever you see any case of floppy infant with large tongue and massive cardiomegaly, in ECG, large QRS complex, you need to suspect Pompe's disease. As someone told, here the treatment of choice is enzyme replacement therapy. Sir, what is the cost of this enzyme replacement therapy? It is 10 lakh per kg per year. How much? 10 lakh per kg per year. That's why the concept of crowdfunding has become a hit throughout the world. Or whoever it may be, okay, whoever it may be, all those words are later, just basic class today, okay. Enzyme replacement therapy, right? So here, yes, 2 minutes fast revision, 2 minutes fast revision just now. Listen to me, 2 minutes fast revision now, okay. So 2 minutes fast revision. With respect to hypoglycemia, whenever I see any case of hypoglycemia, invariably I will start the patient on 2 ml per kg of 10% dextrose. If the requirement is more than 12 milligram per kilogram per minute, or if the requirement of no need, just listen to this, or if the requirement of sugar is more than 72 hours, previously it is 7 days, now it is 72 hours, to find the cases easily or in the first instant itself. So the cutoff has been reduced from 7 days to 72 hours right now. So what are all the things you need to see? A classical glycogen storage disorder will manifest in the form of hypoglycemia and hepatomegaly. And based on the biochemistry, how can you make out when your uric acid is increased, triglycerides is increased, and lactic acid is increased, type 1. When triglycerides alone is increased, type 3. When nothing is increased, that is type 4. 1. Second point is, with respect to histopathology, all are PAS positive and diastase sensitive. Next, with respect to other things, your OTPT will be minimally deranged and no fibrosis in case of type 1, whereas in case of type 3, OTPT moderately deranged and minimal fibrosis in type 3, whereas severe cirrhosis and portal hypertension in case of type 4. The treatment is to avoid glucose, galactose, fructose in all these disorders, and you need to take frequent feeding. Third point is, you need to be on uncooked cornstarch so that it will provide you glucose, okay, throughout 24/7. So what is the treatment for type 4? Liver transplantation. Whenever any child comes with severe muscle cramps after exercise, you need to think in terms of a Torres disease, or you need to think in terms of a McArdle's disease. Both will manifest in the form of exercise intolerance, exercise-induced muscle cramps. When it is not treated properly, red-colored urine, as well as your acute renal failure. Whenever you see any case of massive cardiomegaly with floppy infant and large tongue, invariably you need to think in terms of a Pompey's disease. The treatment of choice is enzyme replacement therapy. So with this, a basic introduction with regard to inborn errors of metabolism is over for now. Have a happy Pongal, celebrate well. We will have a very good academic year ahead. Okay, we will meet you with a good teaching plan. Thank you. Thanks a lot. Bye-bye. Love you all. You can wind up right now. Bye. The class is over for now.